Recorded for those of you who have to leave early or will be joining on late. It's a huge pleasure to get this series up and running again. This is our first Columbia Volleyball Center guest speaker we've had on for a little while after a well-publicized pause, which but was really nice to get this going again and get back to talking about the science that we're passionate about pursuing through the Volleyball Center. Most of you know me. My name is Ian Cronish. I'm the co-director of the center along with Natalie Moyes, and I have the great pleasure of introducing Michael Otto today. Michael Otto has been a big friend of the Royal Ball Center and a big collaborator for CBCH more generally through the Science of Behavior Change Initiative and other projects. He's been a mentor to a former recipient of one of our Roy Ball awards in the prior funding period. And yeah, lots of um, appreciation of him coming to talk to us today. For those of you who don't already know Michael, some highlights of his CV. He's a professor in psychological and brain sciences at Boston University. His research lab focuses on developing and validating new psychosocial treatments for mood, anxiety, substance use disorders, as well as for a number of health behaviors, including medication adherence, sleep, and exercise. He has had more than 25 years of funding through the NIH. He's been very productive with over 500 articles, chapters, and books spanning many of his career interests. He's actually one of the ISI's most highly cited researchers and has been the recipient of numerous awards, including the Distinguished Scientific Contributions to Clinical Psychology Award from the American Psychological Association Division 12 and the Outstanding Researcher Award from the Association for Behavioral and Cognitive Therapies. He's also past president of both those organizations. He also has a very impressive track record in mentorship and teaching. He received the Elizabeth Hurlock Beckman Award for Excellence in Mentoring in 2019 and the Toy Caldwell Colbert Award for Distinguished Educator in Clinical Psychology in 2023. Super impressive. And he's also been the founder of the Mechanistic Behavior Chain Research Consortium and the Exposure Therapy Consortium, which are both very relevant to the research he's going to tell us about today. The title of his talk is The Role of Interoceptive Exposure in Treating Fears of Somatic Sensations and Associated Avoidance. This is very core to the theme of our Columbia Roybal Center. And with that, I'm going to pass the mic on to Michael to take it from here.
Thank you so much, Ian. I'm delighted to be here. It's going to take me a moment to click a couple things and get my slides up. But a word about that. I'm going to make great use of the slides here for a bit, but eventually make sure you pin me, and I'm going to tell you when I'm going to ask you to drag me. I'm up in your right-hand corner, presumably. Drag me a little bit larger so I can exemplify and show you some things. So you're staring at my song and dance rather than the screen, but not yet. We got a way to go here. First, let me do my disclosures. The one industry thing is a link to Big Health. That is for app-based care. We're not talking about that today, but I wanted to mention it. I do get book royalties, and let me mention a couple that are relevant to today. The exposure-based approach is nicely detailed in the personalized exposure therapy, and the idea that interoceptive exposure is part of treatment for every single one of the anxiety-related disorders. We're also going to touch on the theme of a core construct of anxiety sensitivity. That's a talk in itself. That'll just be quick. And then you know, of approaches where we take interoceptive exposure and apply it to physiologically driven symptoms. One of the great examples that is helping people stop anxiety medication, namely benzodiazepines, where you're going to have a symptom drive no matter what you do as you taper down, and to help people respond differently to the symptom drive. It is the holiday season, just perfect gifts for the whole family, for the kids, undoubtedly. All right, here's an outline for today. So we're going to start very conceptual. We're going to start conceptual with exposure, and the target of the exposure for today is a fear of symptoms. I'm going to use anxiety treatment to underscore some of the principles, but the idea is to be able to pivot to those to fears of symptoms that arise as part of a medical condition, may even arise co-emergent with a medical condition, but we're still looking at the fear of those symptoms based on the medical condition. And then we're going to get very clinical, and I'm going to lead you through some interoceptive exposure. And that's when you're going to make me bigger on your screen so you can actually see me. So that's where we're going. Let's get to it so we have enough time. I'm going to start with the big lie of my graduate training. No, it's the first big lie was your stipend is a living wage. That was the first slide. The second one, though, was that exposure therapy with its core mechanism of extinction is a successive weakening of a learned association. And it was a good lie because that was the conceptualization for animal theorists and clinical workers at the time, that it was a successive weakening. Since that time, there's been a wealth of evidence. I cite Mark Boughton, one of our University of Vermont animal researchers. He just makes such a compelling case in a variety of different articles that extinction is new learning. It is a new learning of safety that competes with and hopefully dominates over a treatment response is when that safety learning dominates over the older fear learning, the fear learning that was there before they came to treatment with me. But he also comes with a caveat. New learning tends to be context dependent. You don't wipe out an old memory. It sort of emerges next to it, competes with it. And I want to keep that idea going because I like the idea of a competition between the memories. In my metaphor here, a jousting between the memories just helps me think that I've got to win a certain competition. The patient is better when memories of the safety learning, memories of safety in relation to the feared cues, extends across enough contexts and sort of controls the adaptive behavior they want. So active jousting, active learning, but two bullets here that are both important. One is changing the emotional response, the fear, and that's what patients say, help me doc with the fear. That's what I get over in anxiety disorder land. But as important is changing the behavioral repertoire with the fear cue. And the behavioral repertoire at the associative learning level, it's happened very, very fast, but keep in mind that all behavioral repertoires have a lot of chaining. What you do in those first milliseconds, in the first 3 seconds, in the first 10 seconds is sort of chained into the next 10 seconds and then the next minute, etc. So partly we're changing the behavioral arc at the beginning to try to get non-phobic responses in relation to the fear cue. And to give one more animal researcher, Ledoux is sort of tapping the clinical field on the shoulder and say, look, remember in the rats, when you're measuring at the millisecond level of the connectivity between the fear cue and the firing of the response, the behavioral response, the threat response beats the emotional response. And that's sort of useful for me just to remember that with the natural focus on just stop the fear, doc, it's important to say, no, we've got something very fundamental in there with the fear response that we have to attend to. All right, so let's run with this. If extinction is not a weakening of an old, you observe it behaviorally as a weakening, but centrally in the brain, it's new learning. What are the implications of that? Well, it's not a slow rote process. We're not just dealing with repetition, repetition, repetition to win the battle, but it's an active new process. And there's some good news in that. My job is to make that salient. My job as a clinician is to bring good ideas to the process to sort of win this jousting competition as best I can. And I can bring to bear all sorts of things. My example here is including older memories, memories that may have even predated the fear learning, which can help adaptive, safe learning win the competition. So I will, when we focus on me and my clinical examples, I'll show you what I mean by that. But first, one more important conceptual piece. There's lots of ways for us to divide up people's brains, right? I'm going to do it in the most simplistic way. We have a limbic system, we have a cortex, and we have appropriate learning to both those systems. We have nice associative learning, stimulus response. We have a cue, which gets tied in the anxiety disorders to fear and these threat-driven behaviors. And separate from that, though, we have Q tied to a conceptual fear. Oh my God, this is bad. Now, I'm putting up apparently, I think everybody's cortex speaks with a Shakespearean lilt. But what I have up there is, this perchance, what is the learning and therapy? Perchance this is not as concerning as it seems. I think I'm getting better. So therapy needs, we have two sets of learning I like my clinicians to keep in mind, the associative learning and the declarative model-based learning. And we want both of those to be in agreement because we don't know with which patient, with which cue, which is going to dominate. Although we do know that the associative learning tends to be more powerful under conditions of stress. And those are the conditions that we're always under when we treat anxiety disorders. Anyway, uh, what are we going to do for the associative? That is the land of exposure therapy, corrective learned experiences, learning from experiences. And then for the declarative, my slides aren't enjoying my click here. There we go. We also have information that we give people about the nature of their condition and all the cognitive restructuring. But there's a form of that I want to emphasize is really important. There's a form of that that really is an extension of exposure therapy, and that's the post-exposure processing. What did you make of what we just did? How might what we just did in today's session influence you going forward over the next week? What do you want to remember from today's session? Now, one important thing about this, again, another talk, I have this sort of memory-centric take on exposure therapy. Just want to remind everybody that the initial consolidation period for a memory, not too precise, is somewhere between 10 minutes and 4 hours. And so I like clinicians to think that what they leave this session with is part of the exposure memory. What they think about on the drive home, if it's a live session, does become part of the exposure memory. So helping with the conceptualization of what happened can change the original safety memory that's put in. Now, there's reconsolidation during the week, but for today's talk, we're just focusing on also being aware of and getting good frame for that post-exposure processing. All right, so here's what we're doing. In our exposure therapy, we have associative learning, and we do have this declarative model-based component that is part of exposure. What are we talking about in today's talk? Afraid of what? I should warn people, but I just can't help it. Let's talk about spider, that's a snake, Michael. Fear of snakes. Now, some of you, just because it came on your screens right away, had a little jolt to this, right? Some of you over there may hate snakes. I'm sorry if you hate snakes, but let's use your experience. When this came up, you got bit. You didn't get bit by the snake. You got bit by your emotional experience. So, the snake, And that's true of people who have really strong snake phobias. Snakes aren't biting them. What is biting them is their own experience of their anxiety, the fear response, which can be so aversive that people avoid snakes for a lifetime despite very little direct acquisition experience. The harmful consequence is how people feel, even with a phobia like this. So that suggests a couple things for treatment. Part of my job is to treat the fear of the internal experience that is evoked by that snake. And then part of it is I do have to treat the fear of the external cue. And especially with snakes are also viewed as kind of icky. And so there's a little bit of a disgust reaction that can be part of someone's overall negative reaction. But all right, two parts. Even with something as straightforward as fear of snakes, which is so often treated by direct cue exposure to the snake, we can first do internal exposure and then do fear. Now, that can be really important under certain conditions. Oh, here's Lester Holt. Let's talk about one of those conditions. So Lester Holt, as you might remember, I think did the Today Show before he became a primary anchor and the sort of presidential debate anchor he was not too long ago. So he worked for the Today Show, and at one point in the Today Show, he has an interview coming up with Samuel Jackson, and this is to promote the movie Snakes on a Plane. And for the shot that they have for Today Show, is Samuel Jackson's supposed to stand there and have a big, I think yellow, as I remember, boa constrictor around his shoulders. And Lester Holt says, I can't do that. I don't, no, no, takes the snake down. I can't do that. Now, there's two parts of it. Obviously, Lester has an emotional experience saying, I can't do that. But the adaptive behavior that he is paid to do, which is interview Samuel Jackson, is offline under conditions of this apparent fear. Now, the producers, being great producers that they are, think, oh, that's too bad. We'll do that. And then they remember, and coming up on Sweeps Week, right? What do you have to do on Sweeps Week? You have to maximize your viewership because that determines your revenue. This is old-fashioned TV with advertisements. So Sweeps Weeks, we got to get lots of viewership. And the producer thinks, it would be cool. We should take our anchors and put them all in treatment for what they hate. Hey, let's get some anxiety guy to treat Lester Holt. So Lester Holt, it turns out, is coming up to my office, and they're giving me all of 2 hours to do some anxiety treatment of Lester's fear of snakes. Now I can do the thing. I go out, I rent some snakes. I get 3 snakes in the office. That's not those snakes, but 3 very different colored snakes in the office. But the post test for Lester Holt, which is coming up, a day after, whenever they arrange it, he's going to go to the zoo. Now, that's not a picture of the zoo snake, but the zoo snakes are substantially different in Q from the snakes that I have in my office. So what can I do? I don't want to get embarrassed. I don't want Lester to be embarrassed on national television. I don't want my treatment to be embarrassed. I only have 2 hours. So I could sort of pre-treat what is truly cross-situational, that I can help Lester be cool with the feelings he's going to get when he sees the snake, especially because probably the zoo snake's going to be a little bit more evocative than the little snakes in my office. But also, I'm going to do the exposure to look and feel of a live snake. So we do interoceptive exposure. That's coming up. You'll see the list of the feelings Lester Holt gets when he sees a snake. We're helping him respond differently to those feelings all by themselves. And then at some point, I'm going to say, hey, I'm going to use the snake. I'm going to give you some of the same feelings. And I want you to get used to the snake and touch the snake. The new thought, it's icky and slimy and grotesque. Well, it feels like a really nice boot too. A different frame for the snake. And then, he goes off and has to perform, be Lester Holt. They want to, what does the producer want? They do want him to tremble a bit, right? But they want him to overcome on camera, and he does just fine with that. So that's the idea of partitioning up the fears and the idea that exposure to the internal sensation is really cross-situational, can prep someone when it's hard to pre-expose them to everything in the repertoire. And so interoceptive exposure targets fear of somatic sensations. I'm going to take just a brief tangent here from treatment to go a little bit broader. Interoceptive exposure is targeted to fear of somatic sensations. I'm going to relabel that anxiety sensitivity as a great measure of fears of somatic sensations. What somatic sensations? Well, the list on the anxiety sensitivity index, various forms, are those sensations that are evoked when you're anxious for most people. So the importance of tracking these fears in terms of anxiety sensitivity is that you get lots more research. And so let's take one moment with that research. Here's a broader model. Here we're talking about fear of dyspnea. So the sensation that is somehow in the chest, near the lungs, somewhere getting a feedback that says, uh-oh, there's a little bit of dyspnea starting. And think of anxiety sensitivity as the magnifying glass. It is an amplifier of the aversiveness of those sensations. I can't stand this feeling being the cognition that sort of goes with that. And what gets amplified with the fear are the maladaptive responses. We've amplified a fear, in this case, of a particular medical symptom. Uh, Amplified, says the research, is the disability that goes with the objective degree of dyspnea. What goes with that is avoidance of healthy activities that may help you withstand the basic disease process or recover from it, or engagement in unhealthy behaviors. You know what would help me right now? A good stiff drink, right, would be an example of an engagement of unhealthy behavior that's driven by, I can't stand this feeling, I'm anxious about it, rather than being driven by the somatic sensation itself. So that's our setup of the broader sense of what we might treat with interoceptive exposure. And here's a way of saying it. This talk is about using interoceptive exposure to engage fears of symptoms, aka anxiety sensitivity, as a mechanistic target that's underlying all sorts of things we care about. First bullet is where I spend my, most of the day job. More of my work is in anxiety disorders and health behaviors. Here's how core to treatment of panic disorder, core to all sorts of the treatments. Well, you'll see in a moment, but also treating distress and disability in response to fears of symptoms driven by health conditions, as well as more generally um, attending to the way in which anxiety sensitivity disrupts all sorts of health behaviors. Great research for a way it leads to exercise avoidance, smoking, increased alcohol use, stress-induced eating, etc. So we have lots of health targets that come out of this concern, and we have a method that we're going to talk about. Now, central to that method, one more conceptual point here before we get down to the clinical stuff. Everything we're doing is differentiating true alarm from a false alarm. An anxiety disorder is defined as a false alarm. Your anxiety response, oh my God, danger, danger, danger signal, the alarm is going off in our body for something that the DSM says, baby, that's safe. That's safe. That's a false alarm. And so we are training people up to, shut down the alarm bell to false alarms instead of true alarms. The idea of true versus false is very important with medical conditions. So that's why we're going to attend to this. Um, PTSD. Let me explain to the true alarm. Let's use me. Let's say I was assaulted at 11:25 on a Friday when I'm on my way to go give a talk somewhere, an actual live talk. Happens outside a classroom at Boston University. Now, if the assault is bad enough and is traumatic enough, I will get a fear, not just of the true alarm. Let's say a very angry, distressed looking person with a knife. That's the core of, what is the signal of the danger? Angry looking person with a knife. If I get PTSD, what else is in there? Friday morning, 11:30 on a cold morning can get in my what I'm reacted to. Fridays, being at school, walking alone anywhere, right? So part of what PTSD is, your reactivity is to elements of the memory that are all false alarms. I just want to say when we treat PTSD, we never try to make people less scared of an angry looking, distressed person with a knife standing near you when you're alone. Keep that forever, baby. That is a true alarm, but we differentiate the false alarms. Likewise, if we're talking about treating fears in relation to the medical symptoms, we can presume that there's a core set of symptoms that need action. Appropriate medical action is defined by the patient's physicians, and there's all sorts of feel-like symptoms. And in the same way as we see over here, oh, something you didn't see over here. It's a bad part of the graphic, but I narrowed down like someone is well, they keep big alarm to the true alarm, right? We want to make sure. And one thing that happens in with PT is you train up appropriate response. In this case, run away, call the police. If you see an angry looking person with a knife, great, go call the police. So maybe train up the adaptive response here, while the adaptive response for all this is be cool. You're at work, baby. It's Friday. We don't need to be afraid of every Friday at 11:30. Whoops. Same thing over here. We're reducing the amount of alarm to the feel-like symptoms, and we're training up adaptive responses, especially to the false alarms, but maybe to the true alarm now. When do you call your doctor? But all the false alarm symptoms have such a medical cost, as the Columbia Center, is shouting out, you develop a PTSD reaction to your cardiac condition. You get all these awful downstream stuff, whether it's sleep disruption or avoidance of your visits, only use of the ER, not following up on your cardiac care, not exercising as your physician recommended. Um, those are the adaptive responses that need to occur despite the feel-like symptoms. And here's how we do that. We're getting to the meat, people. So, random symptom. Let's take dizziness. And there's a maladaptive response going off on the left side of your screen. This sort of, uh-oh, what if? And these are all written around panic disorder, but you'll notice they're the same as many of the medical patients. What if it gets worse? Panic is kind of specific. What if I lose control? Medical for panic patient. Now, what if this is a stroke? This is a sign of a heart attack. Oh my God, am I going to faint? Am I going to fall down? I've got to control this. And the control this is that sort of tense up, tighten up response to it, which very easily in panic drives more symptoms. I think it's getting worse. And then you do something that helps drive more symptoms. What we're training up in exposure, interoceptive exposure in particular, is not ignorance. Sure, let's notice the sensation, but let's do nothing to control it. My wording here, very important. Relax with the sensation. Do not relax. No, we're never trying to get rid of the sensation. We're trying to get comfortable with it. In panic disorder, you get comfortable with it, it goes away. But we're stopping trying to control it. So the word relax there is meant to say, do the non-anxiogenic thing in response to this, rather than try to relax it away. And of course, we have to do that across contexts. People feel awfully safe. There's someone sitting in a medical, when I used to be at Mass General, and when someone's coming to treatment at Mass General, they know there's endless help outside the door, but that's very different from experiencing the symptoms at home. That's why we have to first do it in the office with a therapist or on Zoom with the therapist. That works just fine too. And then have them practice it independently of the treatment context and us to spread this across contexts. And what are we doing? We're doing the green now. We're helping them relax with the sensation and embrace normal behavior. There is this weird part of Interoceptive saying, what do people usually do with this? And how can you over encourage it? I'll come back to that. With a medical condition, there is a little bit of, if this is a false, is this a true or false alarm? If it's a true alarm, what am I supposed to do? If it's a false alarm, what do I do? So there's a little bit of learning in the context of the cue. Here's just some of our interoceptive exposure. So we're going to have you look at this, but this is the time anywhere in here that you can go to my pinned picture and drag it larger so you can see me, not just the slide. I'll give you some examples. We're going to start with head rolling. And in most of our protocols, we always start with head rolling because it's not so bad. The stimulus response is just so clear, it's limited. You could turn it on, you could turn it off. Hyperventilation, those symptoms can last for a bit, and a lot of our patients will respond to a little bit of hyperventilation by breathing like this, right? So that has a little bit more of a tail because people don't necessarily stop hyperventilating when you ask them to. And it's more of a storm. So starting with head rolling, let me give you a sense of things here. Oddly enough, I pulled a muscle and I've had some neck pain. So there's who do we not do this on? Someone's fresh from a car accident. No, we don't have them roll their head around much, right? We're aware. Actually, just click some bad. We're aware of, by the way, did I stay up or did I lose the view? I can't tell on my computer. Do you guys still have the full view?
No, we're just seeing like there we go.
All right, good. We're back to, thank you. Back to the full view. All right. So go back to the slide I'm meant to be on, go back this way. Um, So there's times when you may not choose those because of a medical liability, like an injured neck. Mine's been extra tight, but it's fine. And one thing about head rolling is you go from midline down and around. That's much less hard on your neck than going way back here. But also, if someone can't turn their neck, they can just say no, that'll do it. They can swivel in their swivel chair. Down there later is actual chair spinning, which is doing this. Um, that's tougher and that induces nausea. That's great if that's your target sensation. That's not great if it's not your target sensation. Anyway, let's say I would do head rolling with a patient. If you would like to do this with me and you're not medically compromised on your neck, what we're going to do is I'm going to ask you to remember to breathe because some people go, well, that's a drag. Now we have two things going on. We have the breath holding plus the head rolling. So I remind people to breathe, drop their head down and around. We may even loosen up the neck first. But here's the core of it. I'm going to do it because we only have so much time. And I'm starting to get those feelings of being odd, off center, a little bit of dizzy. And yes, I do this during my talks all the time. I can lecture in front of 150 people and be dizzy as can be from this. And I stop and the world goes past and then centers. Now that's me doing it. A patient with their salt with panic disorder will finish the head roll and will brace against the sensation. And I'll say, what did you feel? And they'll say, I don't know. I just had to make it stop. So we see how rapidly they go to the defensive response. So then do an old-fashioned exposure. I'll say, well, we're going to do it again. Take a moment. This time, I really want to know what's so bad about it. And I'm going to ask you to try to get some more words. So when you're doing it, say, how am I going to describe this to Michael? And people use words like dizzy or odd or off center. Some people go right to out of control. That's not a sensation. I want to know what is the sensation that leads you to say I'm not in control. So let's do it again. So people do it again. They get a little bracing, but they have more of a verbal repertoire. They kind of kept their head about it more. And they say, well, I'm off center. It felt weird. I say, it really does feel weird, doesn't it? What's so bad about weird? I don't like it. It reminds me of this. It's part of my panic. I don't want it to get worse. And so many of the fears you get at that moment of therapy is this idea that it's going to escalate, get out of control. Well, before it actually got worse, how bad was it? Well, I didn't like it. Yeah, all right. Now let me pause. We're going to depart from limbic system only repetition exposure. And I'm going to get very manipulative because I want to win the competition against the fear learning. So I will say, like I'm going to say to my audience now, how many of you, when you were a kid, um, would spin around in a circle with your friends to get dizzy and then try to walk straight? Or how many of you would sort of spin around standing up or roll down a hill to get dizzy? Or the weird thing, which I never heard about in New Mexico, is that people go to home base, put a baseball bat on home base, put their head on the baseball bat and walk around it. That's the weird thing. Apparently, kids in the East do. But if I ask my audience of panic patients, how many of those people did that? I get almost everybody, just like you guys, you're off screen. But if you all raise your hand, it'd be everybody. I had a group, I had a workshop, about 30 people, 30 out of 30 said they did that. Same with your anxiety patients. And now I'm going to build the memory and I'm going to say, who did you do that with? Oh, your friend Johnny. When I did it, we did in summer, we did it in a park. Where'd you do it? Oh, backyard? Did you do it in the grass? Fall down? Yeah. Oh, God, remember summers, smell of grass and you fall down. It's hilarious. Oh, yeah, yeah, yeah. We talk about it. And I'm building the salience of their own memory of being with their friend Johnny. And I'm including that manipulative olfactory cue to make it that much better of a memory. And I say, huh, and you liked it. Yeah, I liked it. All right, wait, let's do something. I'm going to have you head roll again. But this time when we head roll, I want you to remember what it was like with Johnny in the backyard laughing. And they do it again. And the treatment of panic disorder, about a third of my patients, this is session 2. This is the first interoceptive exposures after providing them with a broader model. They will come up with a smile. They didn't brace, they didn't say, oh my God. They came up with a smile because they recalled dizziness in this other context and realized it's not just dizziness, it's how I interpret it, which is the essence of treatment. And I say that to them, you just got the essence of this treatment, and we're just going to spread that ability that what did fear you, what was very frightening to you, uh, is very different as you are able to experience it differently. And then we march through this hyperventilation. If we do that for a minute, you're going to get all those symptoms. Mask numbness here. Sometimes I get tingle, 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 tingle. And I'm always doing this with the patient and comparing notes in this sort of, I'm modeling curiosity. Wow. And that does feel like your panic, or that does feel like this. Stair running, someone has to be able to do that. Standing in place, I mean, there's all sorts of, less provocative or sometimes safer. Let me mention a couple at the end. Mirror or hand staring. You can either hold the mirror up close, you stare in the mirror, you stare at your own eyes, then you repeat my name is Michael Otto. My name is Michael Otto. And as you do that, you stop feeling like yourself. Or even if you just stare at your hand, at the center of your hand, because your peripheral neurons are going to stop reacting faster. You're going to get 5 fingers, 6 fingers. It's going to look weird. Staring at a Venetian blind with light behind it will lead it to zing and zag. In this sort of in the 90s, interoceptive exposure therapists were calling each other and say, I got something cool. Do this. Stand up, lean over, act like you're getting some out of a file cabinet for 1 minute, then stand up. You'll get this full body tension, you'll get this. Let me mention dread because this is more my lab. Um, sometimes we do pillow squeezes because it's a little bit less. There's sometimes something about not having your hand do it. I have the corner of the pillow, right in my solar plexus. I'm going to hug the pillow. And if you just hold it there and keep hugging, and you can, okay, everybody has it. Get your local pillows. I see Yanni, thank you. Squeeze it. It feels a little bit like dread. And so not for, no, no. What do you, Yanni, what do you have? And you may want,
Me? This
yeah.
is my daughter's
Oh,
Squishmallow.
okay, all right.
Is that the
No,
problem?
no, you can't use an orange sharp. All right, so
Yeah.
take your fist instead, turn it sideways, well below your xiphoid process, and just kind of press it in there. And let's see if that's all
That's
you're going to get
uncomfortable.
from your daughter's pillow is a warm, loving feeling on it. Come on, you can't use that. All right, does
Yeah,
that do any better?
it's unpleasant.
Yeah, unpleasant, and and some of
Dread
these,
is a strong word, but it's
huh?
yeah. Dread
Yeah,
is a strong word, but it's definitely unpleasant.
move it up, and for some people people who are, it's not quite butterflies
Oh,
stomach. It's the, oh, did we get it? I heard an O.
yeah, yeah,
There's
yeah. I went up a little
heavy.
bit, a little sharper with my thumb. Yeah,
All
yeah.
right. So there's this heavy, when I have dread, I feel, heavy in my stomach. You can kind of recreate that. So, and the last bullet, exercise, right? Using exercise itself, right? So I said anxiety sensitivity is a great predictor of avoidance of exercise, especially moderate or greater exercise, right? Light exercise, no big deal, but the more you exercise, the more you feel weird stuff. There's treatment programs, smoking treatment programs, for example. The Jasper Smits and Mike Valinsky have been running directly at their sites that, returning people to exercise helps them respond differently to all the somatic sensations you get when you quit smoking. Again, it's a biological challenge. We are removing nicotine from the system. You're going to have withdrawal sensations. Can we teach someone to be resilient to that using exercise? And we kind of know that it's working as interoceptive exposure, partly because it is targeting anxiety sensitivity. It reduces it, helps people be more successful with their smoking cessation. So you're looking for what people can do. You're sending them home to do it with their spouses. We're always working this, and they kind of relax with it. I will also have people, oh, we can put my feet up on my desk. You can see that barely on my screen. I'm sort of over rehearsing a non control response. So there's this part of manipulating what they do with their body. Uh, if you do this in group, and I've done it in groups, sometimes you'll see, the hunch, control response, or you'll see, and I'll try to minimize what people do. They're averting their eyes. They just so poor in directionality. But you see them averting their eyes, and they're desperately going in their body, trying to control the response. And so in some ways, you got to bring them out. Okay, wait. What are you doing over there, Michelle? Stand on up. Stand on up. Let's stand up, move around. Let's walk around the room. I think you were trying to control your heart rate. Were you? Yes, I was. Well, let's not do that. Your heart knows how fast it wants to beat. Our job is to get comfortable with what your heart's going to decide to do. And then once they do that, what happens? Her heart rate goes down. Um, and that's because panic is an amplification disorder, and PTSD likewise is an amplification disorder. I'm afraid of what where I'm afraid of my own memories, and I'm afraid of what my body does when I have these memories, being a core part of PTSD. So we're driving this. uh Whereas Jeff Burke, you know, he's good because, there's that when you drive into Boston on the Mass Pike, there's that area near Newton where not only is there not a breakdown lane, but there's a concrete wall that goes within 2 feet of the highway. That is, if you're a panic patient, Jeff, you would immediately know that spot and you'd say, that's a top fear spot. I'm on the Mass Turnpike. There's no way to exit. I'm afraid I'm going to panic. So think of the fear box as the core fear plus context. And the context is what people say to themselves, what's playing in my panic patient's head. It's, I'm going to die, I'm going to die, I can't exit, I'm going to have panic, I can't control, I can't pull off, I'm going to die, I'm going to die, I'm going to die. That's part of the stimulus package. They're in the car, they're on the Mass Turnpike, there's no exit. Well, in my treatment, we're first going to do interoceptive exposure in the office. Then I'll send them home to do it. But then we'll do it in the office. So I'll say, go sit in your car so you can get used to, I can have these sensations in the car. And in some ways, this is like we did with Holt. He has to do an interview with a snake, ultimately, to do adaptive behavior in a certain context with the core fear. So we're mixing together. This is now interoceptive exposure, the internal mixed with the external of the car. And eventually I'd say, look, drive several blocks from your house, then do interoceptive exposure, then drive home. And so you can get used to operating a car while feeling off, fine. And then eventually in session, I'll look at him and say, are you sure you're not going to die? You sure this is right? You feel dizzy? You sure that, right? I reintroduce the thoughts so they can learn thoughts and sensation, right? And eventually I built up so much in the safety box, I say, go drive the Mass Pike. And that's kind of redundant to the learned safety. Much of my time here. So if we put all this together, the unfolding of treatment has these elements. Session one is information, partly information on true alarms and false alarms, and helping people understand that their anxiety experience is an alarm bell ringing. It's just going off all the time and it's giving them bad life. We help them think of the alarm bell also in terms of how they experience somatically their anxiety. A little bit different in the medical situation, when you may have a different sort of assessment of what sensations do you now feel? What scares you? What scares you about your heart condition? What reminds you of your heart condition? What does your body do that most feels out of control, etc.? Then setting up the rationale for exposure. And then we're going to go step by step, kind of working toward what their highest fear is, teaching them the ropes on this. And what are the ropes? When I have fear, I kind of do nothing. I notice it. I talk about it with Dr. Otto, but I don't control it. And usually it's easier for people to learn this non-response around lower level fears, right? So now I've learned what Ledoux cares about is I don't go into my defensive behavior. I just sit here and see what that's like. And then we march that response and getting comfortable with the sensations toward more concerning sensations for that particular patient. And then we're doing they do it with me, then they do it home. And the unfolding of treatment is, increasing the intensity and the accurate targeting of my interoceptive exposure. Um, and then making it, I'm sorry, I was supposed to say increasingly vulnerable situations, typo in there, situations, not sensations. So I'm cue and contexting to try to spread this out. And a reminder with that last bullet at every point, if I do what's defined as a fully exposure-based treatment, that does include lots of post-exposure processing at the end of the session. What do you make of this? How do you want to make use of today's experiences in terms of what you do having a good life? All right. Yeah, gosh, Michael, that sure was a non-database presentation. So this is my token slide to say I'm not making this up, that this is applied all over the place and has some nice treatment outcome. Down here in the lower left corner, I showed the book on our personalized transdiagnostic. This treatment certainly is core for panic, but we're doing it with everybody. Doesn't matter if you're primary, no one has just one anxiety disorder. That's not the way they rock. Virtually no one. It's for people with primary panic or PTSD or social anxiety disorder or generalized anxiety disorder or OCD. The first part of treatment for all those is interoceptive exposure. We change their experience on how they react to their anxiety. And then we go forward with more disorder-specific exposures. Oh, I think I saw Samantha Harris there. Really nice review of some of the nice range of interoceptive exposure and targeting of physical discomfort transdiagnostically. I should also say it's been applied some in prevention models as well. What negative health behaviors or anxiety or depressive problems can you head off? I included this exercise. This particular citation happens to be of the mechanism. They really do get better because the exercise reduces dysphoria and anxiety sensitivity. Exercise is kind of a great treatment for depression, let's not forget. All right, this is my question slide, but also I'm looking for folks that may also want to join the consortium. This has been our other consortium, the Exposure Therapy Consortium, founded by Jasper Smits, has been going great. We're work groups are on the third and fourth project. Our second project was run in a year and a half. 530, I keep misremembering, 531 people run in a semester and a half. Now, it was a student-based study allowing that, but it says that a consortium that is not funded really can do some great stuff. And if for some of you in a medical setting who don't have an access to a whole bunch of young adults that you may want to work out measures on, you may want to work out the nature of your measurements on, right? All of it doesn't have to be clinical outcomes. So this is saying up there so you can get your phone and scan the QR code. I promise as soon as I led the second ETC project, almost done writing that up, then I'll turn my attentions back here because the third and fourth ones are now running, just progressing toward the design nicely in the work groups for the other consortia. Anyway, it's time for me to say really, truly ask questions, and let me stop the share. And we have a little bit of time, and I'm going to make you all much bigger.
Thank you so much, Michael. Amazing, amazing talk. Really fun to be big picture and clinical, and have a sense of what you do in the office. So thank you so much for sharing. I know there are a bunch of people that probably have comments, questions. So I'll kind of open the floor up to, we have an amazing group of audience today with a lot of expertise.
Jump in there.
Put in the chat or just sort of raise their hand and I'll acknowledge them. Yep. Go for it, Yoni.
Thanks, Michael. This was a really fantastic talk. I really appreciate it. And very aligned with my thinking. So also clarifying for me in terms of I'm working with exposure therapies for chronic pain, and so also clarifying for me. A few questions. We'll see how many we have time for. But one is, so this distinction between exposure to the cue versus exposure to the internal response to the cue. Do you view that as a relatively more recent distinction that people are making in exposure therapy, or has that been there since the beginning? Because the way I was trained was really focused on exposure to the cue and not as much interoceptively. And related to that, it seems like the interoceptive exposure, you would hypothesize that would be more effective because, like you're like saying with the snake, like it would generalize across situations. It could also generalize transdiagnostically instead of just treating your OCD. You're treating everything at once.
You're
And so,
treating emotional tolerance. Yes, yes.
exactly. So, do we have evidence that focusing on the internal experience is in fact more effective than focusing on the cue?
All right. So first part of the question, is it more recent? Yeah, with as long as people have been treating anxiety-related disorders with exposure, it wasn't until kind of the 80s and 90s that intercepted exposure emerged at all. And then it emerged for panic disorder and then got ignored for all the rest,
Yeah.
despite everybody knowing there this is what's going on. Now, in one of our early reviews, Rich McNally said, but when you do, let's say you do exposure for agoraphobia, you are exposing them to both because they're at the mall and they're fearful and they're feeling it. And our response back, this was for the publication, an early publication, we said yes, but the effect sizes have gone up once people partition them out and honed each separately so that the panic disorder treatment effect sizes took a jump at that time in the literature. So even though topographically you're saying you're getting both, honing attention on each one separately seems to be leading to bigger effect sizes. This last part of the question is like, okay, do we know treatment is more effective? Only kind of. We kept marching down the number of sessions. We do know that my 5 session interceptive exposure heavy treatment provides outcome at least as good as Barlow's, whatever it was, 15 session treatment where he does only some interceptive exposure at the end. So it does look like when you load in more of that mechanistically targeted stuff, treatments get much shorter. But that head-to-head trial of doing it one way versus the other way without the shortening, I don't know anybody who's going to fund that one. Yeah, given right, the zeitgeist moved on. Now, relative to your stuff, also we just had a trial at UCLA where our patients were a little bit between us. They're individuals using opioids and benzodiazepines. Everybody's thinking, oh, isn't that number one cause of overdose deaths? Yes, it is. And so medically, they needed to go off the benzos, what we targeted. Um, and they didn't necessarily want to go off. They're like, I haven't died yet. Why would I go off? I like this mix, but they still slow hard recruiting, got them in. But a lot of those patients also had pain. So we had to do a little bit of pain exposure as well as our interceptive exposure, where we just did stuff like squeezing in here or finding a pain point and just practicing that same interceptive exposure response to a pain cue like they do to an anxiety cue. And whenever we did it, I thought, oh, I'm a little bit like Yoni, just a little bit. Yeah.
Thanks for that.
All right, Don, I think you're next with your hand up.
Hey, fantastic talk. Thank you, Michael. I always love watching you talk, and this was particularly useful for me. I have a question that may be theoretical, and I want to hear your thinking about it. So one of the things that struck me when you were talking about some of these clinical examples was the notion of patients trying to control the sensations, trying to, going into this. And I'm thinking about our cardiac patients, our stroke patients, who are dealing with this notion of maybe some are on beta blockers, maybe some on medications, maybe the doctor is talking to them about, hey, we're trying to control your heart, we're trying to influence some control over these processes physiologically, and I wonder where the sort of nuanced messaging for a cardiac patient of like, you can't control what does that look like?
All right, it's great. Yeah, because issues of control always come up in panic disorder, and it's partly a redefinition of what control is. Hey, I need to control my pen. Oh yeah, I never know if there's going to be an evil pen or not. Now, look at me control my pen. I am controlling the pen and I've lost complete usage of my hands and my attention. The other way of controlling the pen, I have complete control of myself with respect to the pen. I can go get it if I need it. But what I get with this kind of control is look at all the stuff I could do when I'm not trying that other method of control. So it is, the control of panic is this false bearing down or whatever people try to do. Um, it is, the control we give people always is a return to their value-driven actions. That's what we ask them to do. And we ask them to incorporate the, physician's wish list in that too. Baby, that includes exercise now. That's going to save your life over time. So your control over your heart, if you really want control over your heart, it's going to be following through with taking those meds on time and doing your exercise, like your treatment team is saying. That's the only control you can exert. Otherwise, we let the meds do their job. But yeah. And when you exercise, how can we make that as pleasant as possible? Because my God, that's scary. You're a cardiac patient now. No one likes that label. And yes, you got to exercise, but how can we make it more fun? How about that pickleball? Sorry to go for that. Yeah. No,
Thanks,
there would
Michael.
be no real exercise there. Yeah. Yeah. Someone's just up. Anybody else? I know we have waning time. Jeff.
Almost out of time, but I just want to ask a great to talk and great to hear see you again. Saw you recently in New Orleans. I wanted to ask very briefly about so if a patient comes in with a particular, let's say again, CVD patient, and they have sort of a fear of chest tightness, which is a recurrent symptom, and they don't tend to experience, let's say, dizziness. IE will do a whole broad suite of interoceptive sensations that are targeted. Is there reason to believe that you might sort of vaccinate against dizziness anxiety if it were to arise in the future in this patient who didn't previously have an issue with dizziness specifically? I'm just curious about that because
Um,
it relates to the PPG, obviously.
Yeah, so yes, there is some evidence. So the panic prevention programs have been a couple that it does seem to vaccinate against. Let me be careful here. It doesn't cause stoicism. Our aim is not stoicism. Stoicism. Our aim is adaptive responding in response to symptoms. For your medical patients, that adaptive responding has to include um, knowing when to react. What symptom? When does your doctor want you to call? And what do they not say you don't need to call about? Let's divide those up. Same thing like PTSD. There's a true alarm, there's false alarms. And yes, doing a broader suite can vaccinate people for the future because they know, oh, I did this. And the knowledge is partly all sorts of weird things can bring up these symptoms. And even in panic patients, there's this emergence. Boy, there's one little point I want to make. We did a project with Cambodians. We went to Chelsea where there's a high proportion of refugees of the Pol Pot era and did treatment in a temple there with a translator. And we ran into this cultural phenomena that a sore neck could represent blockade of this cultural distinct belief about wind that needs, wind needs to travel through the body, kind of like ki. And if that's blocked, it can kill you. Your head can explode internally, you die. And of course, everybody with PTSD, which is what we were treating from this god awful Pol Pot era trauma, had sore necks, right? Most of you get sore necks when you're stressed. And so here we had this cultural interpretation differences. Hey, your culture is wrong. We're going to say it's tough. It's hard to know which it is. What we're going to do is we're going to induce it so that sometimes it's not wind. And if you know it's sometimes not wind, you got to maybe get better at noticing when it's not wind versus when it is wind, because not wind is just muscle tension. That's not going to kill you, no big deal. And in some ways, that's a great analog for a lot of the medical patients. And I had this one patient that she'd panic every morning, and we're doing all sorts of interoceptive exposure. And then we are doing one on the derealization. She said, "Oh my God, oh my God, oh my God, oh my God. I just realized every morning my boss comes in to detail what's happening for the day. And every day he comes in, he stands in front of my Venetian blinds when it's bright and sunny. And it starts zinging. And I thought that was my panic. And it's the stupid Venetian blinds, right? So the sense of I get symptoms from all sorts of stuff. Sometimes when I'm nervous, sometimes when I'm scared, sometimes because I had to get something out of the bottom file cabinet and I stood there with locked legs and reached bent way over. And sometimes because someone stands in front of Venetian blinds. So it's this sense of symptoms come from all sorts of stuff. And I don't need to automatically scare them. And that's some of, back to your question, Jeff, that's some of the inoculation effect that my body does some weird stuff. And, I got to check with my doc, given that I have a cardiac condition for those people who are diagnosed. I got to know what the true, when do I call? When do I not call? Um, Otherwise, I notice them, I note them and relax with them and go about my value driven action.
I
Well,
know we're with the hour, Mike. I think people do have more questions, but I think they're also trying to be respectful of time.
people
Uh,
have their lives, don't they? Yes.
but honestly, thank you so much for this. Again, this has really been a core concept that obviously with the PPG and other things, we're really excited about exploring, particularly medical populations. Yeah, this seems like something that we could probably teach primary care doctors. Yeah, really would love to see how far this concept can go and how much we can integrate into common things that are being done in healthcare. Uh, um, we will have more of these in the future, so stay tuned for we have an upcoming speaker that's an implementation scientist from the NIH. So more details will come about that. And we'll be announcing our Roy Ball competition awardee and after the holidays. Yeah, so everyone, thank you so much for getting together and look forward to staying in touch.
Great. Thank you, Ian. Thank you, Michael.